Good afternoon, dear viewers. I'm Dr. Lakshman, a consultant surgeon in Bangalore. It's a great pleasure to welcome all of you to this webinar on an approach to rectal cancers and recent advances. This webinar is an appreciable ASI initiative to bring the cutting-edge knowledge of surgery in various specialized fields to all of us across the country. With so much confusing literature being put out across the world, it is a challenge for all of us to decipher what is clinically important and relevant. Also, specialists like Dr. Somashekhar help us understand controversies which are common in many areas of surgery. I would like to thank ASI and Healthium for conceptualizing this webinar and bringing it to all of us across the country. It is a pleasure to introduce Professor Somashekhar to all of you. Professor Somashekhar is the chairman of Manipal Cancer Center. He is the head of the Department of Surgical and Gynecological Oncology. He is also the director of the HIPEC program and is the director of the Robotic Surgery Fellowship of Manipal University. He got his MCH in Oncosurgery from the Regional Cancer Center, Ahmedabad, with a university gold medal. He is a fellow of the Royal College of Surgeons of Edinburgh. He is a recipient of the Gujarat University gold medal and is a director of Manipal University Breast Surgery Fellowship program. He is also the president of the Association of Breast Surgeons of India and the editor-in-chief of the Springer Indian Journal of Gynecological Oncology. He has been awarded the prestigious Dr. D.D. Patel Gold Medal for excellence in oncosurgery. He is an author of several textbooks of oncology and is the director of Board of Studies at Manipal University, Manipal Hospital. He has several publications in indexed national and international journals. It is indeed a pleasure for us to have him here talk about rectal cancers. I would like to remind you to send in questions by the webinar chat box or on WhatsApp. The number to WhatsApp is 7899 723391. I repeat, 7899 723391. Over to Professor Somashekhar now.
Good afternoon, dear colleagues, my senior, postgraduates, fellows, and students. I am Professor Dr. Somashekhar. I am a chairman and head of surgical oncology at Manipal Comprehensive Cancer Center, Manipal Hospital, Bangalore. It's a pleasure to address all of you, and I thank the ASI for this excellent educative webinar initiative they have taken. I bring warm regards from Bangalore. Today, the topic of my discussion and talk is rectal cancers. I'm going to cover surgical aspects, oncological perspective, and functional outcome, and also I'm going to touch upon in my last 5-10 minutes about the recent advances that has happened in couple of last 2-3 years in rectal cancer. I bring warm regards from the cancer center. If you look at what is the main goal of the rectal cancer, it is very, very important to understand rectal cancer is a surgically treated disease. In no other cancer, the type of surgical effort you put would translate into the locoregional control, quality of life, and cure. So the surgical skill has to be to its highest zenith. So the local control of the disease and resulting into cure. If you don't have a loco-regional control in rectal cancer, you cannot achieve cure. No matter what amount of radiation, chemo, immunotherapy you give. Second thing is, since the primary foci and the node is taken off, it prevents the metastatic spread after adequately controlling the systemic disease. Most important is all pelvic malignancies, like head and neck cancer, has profound impact on the quality of life and the function, both the treatment, the disease, and its outcome. So in rectal cancer, maintenance of acceptable quality of life, that is the sphincter preservation, preserving it to normal, near normal rectal function, not just having a sphincter which functions, which is continent, and patient doesn't have like a perineal colostomy, but passes motion with control with reasonable frequency so they can carry on their normal day-to-day function. Also important is preservation of the sexual and urinary function, because they are most important autonomic nerves which control the sexual and the urinary function. So these are the main goal. Now let me see how it can be achieved through my further talk. So sphincter, autonomic nerve preservation, it is called ANP, distal oncologically acceptable negative margin. This is the zenith of the surgery. And somehow restoring the coloanal continuity, either anti-resection, low anti-resection, ultra-low anti-resection, or coloanal intrasphincteric resection and anastomosis, so that patient goes home with a cure, R0 negative resection, with a continent bladder and preserved sexual function. It's very important at the outset to understand, despite expanding interest in chemotherapy and radiation, surgical effort as far as rectal cancer is concerned is the main foundation of all curative therapies. A traditional old-time surgery, putting the hand in the pelvis, zook, doing a blunt dissection, not sharp dissection, not doing a TME, total mesorectal resection, resulted in high local recurrence as high as 30%. Means 1 in 4 is not cured. And the low 5-year survival was because of this. This is a traditional treatment. In my talk, I'm going to cover following aspects. In LAR, ultra-low LAR, APR, means abdominoperineal resection with permanent colostomy and sphincter preservation. Transanal local resection. If you have a tumor which is T1, well differentiated, confined to the submucosa, node negative, analyzed by a transrectal MRI or a endorectal coil, then you can, if you have a TEMS, that is transluminal excision, you can do a local excision. Sphincter preserving surgery either upfront or following neoadjuvant chemoradiation downsizing. And how to do intrasphincteric resection and coloanal anastomosis. The current concept and oncological evidence-based approach of neoadjuvant concomitant chemoradiation. Hand sewn versus staple, double staple versus 3 staple, total mesorectal excision, autonomic nerve preservation. And in selected cases, LLND, that is a lateral lymph node dissection. Where do we place ourselves now in MIS, minimal access surgery, laparoscopic or robotic in rectal cancer? Is there any role of sentinel lymph node biopsy? And if you have a rectal cancer with synchronous liver lesion, is it non-curable, or can synchronous liver and rectum be treated? And if you have a peritoneal metastasis, you open, what is the role of HIPEC currently? So these are some of the topic I will touch, which is highly evidence-based and the current recent advances. Remember, very rarely in a rectal cancer, local resection is possible, which means a resection of mesorectum with node usually is required to cure. But sometimes you may have a very early T1 or T2, which are accessible within the transanal, and you have that special set of instruments. Or you can do a Kirk's posterior proctotomy, or TEMS, transanal endoscopic microsurgery, or laser fragration. Very selected patients, early lesion, well differentiated, not touching the muscle, very good analysis by an endoscopic ultrasound or an MRI to know. So these are local procedures. Then we have radical extirpative organ ablation procedure, which are classified into 2. One with stoma permanent, another stoma is preserved, which means temporary stoma and you preserve the sphincter, which is abdominoperineal resection, which is also called as mild resection. Or you have a Hartmann procedure where you have an advanced disease, a patient who is not fit, so you do a procedure first and close the distal stump. You finish all the radiation chemo, then you come back. Sphincter preserving restorative surgery or anterior resection. Remember, you have anterior resection, posterior. Anterior means anterior to the sacrum through the abdominal wall. Posterior is through the bottom, perineum or backside from the sacrum, approaching it from the backside. Or low anterior resection. Or coloanal anastomosis if you have done an intersphincteric resection. Colonic J pouch procedures, because you give a good reservoir so patient doesn't practically spend up their whole time in the loop. Remember, it is very important to understand rectum is classified into upper, mid and lower. If a tumor is in the lower part compared to upper part rectum, there are two basic differentiation. The low rectal tumor, there is no mesorectum, naturally mesorectum ends. It is the thinnest part. That is where a perforation can happen when you do a resection. And lower part is supplied by inferior hemorrhoidal vessels. They go directly to systemic and lung metastasis is more. Mid and upper is supplied by superior and middle hemorrhoidal vessels, which goes to portosystemic area, and through the portal circulation they go to liver. And there is a mesorectum, and a good TME can control locoregional. So typically it's very important to understand tumor above pelvic reflection, tumor below pelvic reflection. Now for the purpose of surgical management, rectum is divided into upper third, middle third, lower third. Upper third is a easy surgery. They usually behave like colonic cancer and we operate them. Rarely we give neoadjuvant chemoradiation like colonic. They are amenable for upfront surgery. Middle rectum is the place where a good TME is required and sphincter can most of the time be preserved. Lower third is where the surgical skill, evaluation of the grade of the tumor, how far is it from the sphincter, role of neoadjuvant chemoradiation, technique of minimal access come into play to do a sphincter preservation. So remember, lower end liver mats, upper end, lower end lung mats, upper end liver mats. Upper end inferior mesenteric artery, IMA lymph nodes important, lower end lateral pelvic nodes it can go through. 12 cm and above 20 cm is a watershed area, even though rectosigmoid is at 15 cm. Now remember, in oncology, now this is an era not of maximum tolerable treatment. In the old time, we used to bombard the people with whatever maximum treatment they can say, a big surgery, lot of radiation chemo. Now as the oncology evolved, we became wise and we understood this is not an era of maximum tolerable treatment, but an era of minimum effective treatment. Finding the thin watershed line where doing minimum, still keeping oncological principle in mind, but multimodal treatment, but still giving excellent quality of life and organ preservation. So this is an era of minimum effective treatment with organ preservation coupled with multimodality treatment. This is the new concept in oncology. So minimum frequent treatment, but maximum treatment and function outcome. So the local treatment, regional treatment, systemic. Local is total mesorectal excision based on the MERCURY trial, ANP, autonomic nerve preservation. Either you can do by open surgery or minimal access laparoscopic or robotic. Now the new concept for lower tumor is whenever you do a abdominoperineal resection, at the level of liver training, we normally cone down. If you see the specimen, it is not cylindrical. So a new concept of cylindrical, sequential, prone, APE, not APR. APE means abdominoperineal excision. So you don't do a coning at the liver training, but a good specimen comes as a uniform cylinder and you don't breach the mesorectum. Regional nodes is a good retraperineal lymph node dissection up to the IMA, inferior mesenteric artery. In those patients of advanced disease, on imaging you find the lateral nodes. Lateral nodes is internal iliac obturator nodes doing a LLND, or is there any role of SLNB? And then HIPEC and how to manage if you have rectal cancer with an operable liver disease. These are the three main oncological principles. What is the extent of resection for us? And what is autonomic nerve preservation? What is LLND? Remember, AJCC new edition has clearly told in a resected specimen of curative surgery for rectal cancer, minimum 15 lymph nodes should be there. However, if you are given chemo radiation and then you operate, it may be difficult to harvest these nodes, but you must go and gross those specimens with your pathologist to make sure you are staged it well. Now, what is CRM? Most of the time we think, oh, proximally I need to take 5 cm, distally 2 cm, I have achieved a negative margin, which is R0 resection. No. In rectal cancer, circumferential resection margin, CRM, is most important. Remember, in colon cancer, like how we have TME, we have CME, that is complete mesocolic excision. Now, the new concept in colon cancer and upper rectal is central vascular ligation, taking that full mesentery like a frock, frill of a frock, entire mesentery without a wind with all the nodes, which we call Japanese D2CME, is important. As you can see that, in this case you can look, see here, this is involving the ureter and the kidney, and see how in continuity monoblock non-breed resection is done. So that means it is a negative circumferential resection margin to be achieved. Like in this case, you can see that this is a case of post-chemo radiation. See this, at this level, posteriorly mesorectum tumor had breached and a small part of sacrum is resected without breaching this. So you should do anything to achieve a negative circumferential resection margin. In this case, you can see the tumor has gone down anteriorly. So because it has gone down anteriorly, the uterus, the recto-vaginal septum is removed monoblock. So this is an anterior pelvic exenteration yet sphincter preserving, which means to achieve negative circumferential resection margin, whatever it takes. Is it really required? If you look back, this landmark paper published, if the lateral margin, not the proximal and distal musical margin, anterior, posterior, lateral margin, if it is less than 2 mm, it is taken as positive. And various studies, Quick et al. And Koch et al. Has shown that if this margin is less than 2 mm, even if you give radiation or chemo later, it is not going to cure these patients. That's why CRM negative is very important. Second aspect is what is TME, total mesorectal excision. To understand this, this is a great grandfather. I would really want all postgraduates to remember this photo. This is Professor Hield, who first in 1982 defined what is TME, total mesorectal excision. Rectum is covered by its embryological envelope. Rectum has got its outer wall, which is fascia propria. Then you have a pad of fat with lymph node lymphatic. Then you have a visceral layer of rectum, we call it VLPF. Removing all this intact, preserving the nerves, not touching the presacral veins, reduces the local recurrence to less than 5% from 30% even if you don't give RT. This is a landmark paper which was actually published in British Journal of Surgery, which is the landmark paper. I would recommend all postgraduates to go. I had a honor of watching Professor Hield operate in Taiwan when I was doing a workshop there, which is a great guy who identified this. Now, what is the rationale for TME? 60 to 50% of the patient, 80% has a tumor coming out of rectum going into their pad of fat. If you don't do this, you will come up with margin positive. Second thing, most of the time the first echelon lymph node is the lymph node surrounding the tumor around the mesorectum. So imagine if we can remove that packet intact, negative margin, all the important nodes have come, because most of the time the regional spread is virtually confined to the mesorectum. Even when you have a T1 tumor, 5.7% of the time node is positive. As you go to T3, 65% of the time the nodes are there, which means 65% of the time the node that is positive is in the mesorectum. So TME would achieve removal of all these nodes, give negative circumferential resection margin, radial lateral margin will come negative. Automatically, because you go between two planes, VLPF and PLPF, parietal layer, visceral layer of endopelvic fascia, autonomic nerves are preserved, low recurrence rate. It is a bloodless field, so it is not a messy surgery, bloodless field. If the field is contaminated, messy, in order to control them, you lose the nerves, and a safe surgery. So this is what is achieved by the TME. So what is mesorectum? You must know this anatomy. I recommend two important landmark operative book published in Annals of Seminal in Surgical Oncology and Annals of Surgical Oncology, which I'll quote you here. Rectum is a bilobed fat pocket where superior rectal artery continuing of IMA goes down. So there are two fascia. One is VLPF, visceral layer of pelvic fascia, and PLPF, parietal layer of pelvic fascia. Everything inside VLPF belongs to rectum. Tumor nodes should be removed out. You should never breach PLPF because the nerves and the presacral plexus of vessels and all the cavernous now for sexual function and urinary control are here. So the potential space between this VLPF, PLPF is called holy space of healed, which is very important. So you must go in this plane to remove it intact, to reduce local recurrence, preserve the nerves, better sphincter function, and don't cone down the specimen at the level of levator vein. Look at this particular thing which I reproduced from seminars in surgical oncology. See this particular area very clear. Rectal lumen, walls of rectum, rectal wall which is fascia propria, and see this layer outside. This is called as visceral layer of pelvic fascia. So everything between the fascia propria and the visceral layer is called mesorectum. This is where all the nodes, everything run. And the landmark is the superior rectal artery continuing from IMA runs immediately inside of the PLPF, which means if you follow the superior rectal artery and stay outside and keep a layer on that, you will do TME. And now you look at what is the PLPF. This is the parietal layer of pelvic fascia. All the nerve vessels are posterior, and anteriorly Denovillers inner layer and cavernous nerve for bladder and sexual function are inside. So fascia propria to visceral layer, remove everything, don't breach the parietal layer. So this is TME. See this IMA which is being followed, and see this continuing as a superior rectal artery. Impression is seen, but it is not bare or skeletonized. There is a thin layer kept, that is the visceral layer. So this is a TME. We have gone in a holy space of field. Anteriorly, denovular fascia has got two layers. One layer should be preserved with the rectal specimen. The other layer will stay with semivesical prostate. So the cavernous nerve inside are preserved. There are three types of TME: type 1, type 2, type 3. Type 1 is not to be done in malignancies, only in inflammatory bowel disorders or benign. Type 2 is what routinely done, where one layer of denovular fascia is kept with prostate and semivesical, so the nerves are preserved. Type 3 TME is both layer of denovular fascia is taken, where T4 anteriorly placed rectal tumor post radiation. So this figure is very important. Please keep it in mind or take a photo of this. Now you can look back, same thing. So VLPF, PLPF, and then the whole rectal area is here. So you have to remove this whole envelope intact. So the mesorectum and the nodes and the tumor margin is clear. It preserve all the nerves for sexual function. Second important thing is there are only two places where VLPF, PLPF join. Posteriorly at S3, S4 level, the visceral layer, parietal layer join. That is called as rectosacral ligament. Can you see this? Here I have shown you rectosacral ligament. S3, S4 layer, parietal layer joins with visceral layer. If you open anteriorly, mesorectum will open, tumor will recur. If you open posteriorly, you will open the plexus and the nerves, it will bleed, nerves are damaged. So you have to do a sharp dissection and cut this. Second layer is VLPF, PLPF join laterally. So-called lateral rectal pedicle, which is misnomer, where only acidomidal rectal in 20% is present. If you put two clamps and cut, you will injure the nerves. So you should do sharp dissection with a bipolar and then sharp bite scissor and cut exactly between those so the nerves go laterally. So these are the two stress points which are important, you must keep in mind. See this is again depicted by this landmark paper which I showed you. Laterally, VLPF, PLPF join. So you identify the nerves and then do a sharp dissection, no clamps and cut. So anteriorly, this is what I told you, denovular fascia has two layers. If you remove both layers, it is called type 3 TME. Remove one layer, it is called type 2 TME. So this is very, very important. Based on this, we have A type of resection, B type, C type, type 1, 2 and 3. See this is how it is. This is a type 2 TME. You can see that here the seminal vesicle and the prostate is bared, but there is a fascia. So inside that is the cavernous now. If this is a anteriorly placed tumor post radiation, you can see that this is the prostate seminal vesicle, this is the sacrum. We are looking from the perineum. Here the prostate is bare, second layer of denovular fascia is removed. This is a type 3 TME which is warranted in anteriorly placed tumor, T4 to start with post radiation. Here nerve injury chances are very high. When you do such a surgery, you have to put a omentum and separate off so that you don't have adhesions of the small bowel going down. Now I'll explain you this TME again here. This is the specimen of the same patient we have removed. Mucosa of the rectum, wall, muscularis propria. See this is a fascia propria. This is where rectum ends. But look at this layer. This is the visceral layer. So all between the rectal wall of fascia propria and this is the mesorectum. You can see that it can be as thick as 4 to 5 centimeters sometime. And superior rectal artery is here. So if you stay outside the superior rectal artery, keep a thin layer, a good holy space of field will be there. You can see that how the tumor is breached and confined in TME. A good circumferential resection margin, negative margin is achieved. See this is the intact fascia which is in the visceral layer. You can see that. And superior rectal artery, and it is bare, skeletonized but not seen bare. So there is a main fascia. So a good TME looks like a buttock of a baby sitting on your back. See this glistening layer, no breach anywhere, no breaks in the mesorectum, and see this like a small baby sitting with a buttock on either side, fatty, with a median natal cleft. So this is how a specimen, inferior mesenteric artery, superior rectal, impression is seen but not skeletonized, and bilobe fat on either side. So this is how you should look at it, how it goes. So precise technique, what is the technique to do this particular technique? First, IMA ligation, holding the impression, early transection of the colon, following the superior rectal artery, going between VLPF and PLPF, rectosacral ligament S3, S4, way 2 joint cut sharply midway, laterally you do a sharp dissection, no clamp, anteriorly take 1 layer or 2 layer of denovular fascia so it comes intact. So this does a very well hemostatic surgery and excellent. Now, is it just theory or is it useful? So this is a landmark trial which showed if you do TME, the local recurrence drops down from 30% in conventional surgery to 4%. So a good surgery by a surgical technique just reduces from 30 to 4%. Disease-free interval from 50 goes to 75 to 80%. Overall survival jumps from 40% to 75. No better evidence, proof of pudding you need. So good surgery reduces local recurrence, better disease control, better overall survival. So on the backdrop of Dutch TME, that's a Dutch criteria TME, it shows that if you can do a good TME, the perforation in the rectum is very low and circumferential resection margin chance, positivity which is 14% in conventional surgery drops down to 4%. So this is very, very important to do. So traditional surgery, high recurrence, low 5-year survival, perforation chances, coning of specimen. Good TME, reduction of local recurrence less than 4%, good disease control, better overall survival, less chance of coning down, less chance of perforation. If you add radiation to that, the local control recurrence is less than 2%, 98% local regional control. Now look at the second part, which is neoadjuvant chemoradiation. What is the role of this? All patients are not candidate for surgery upfront. If you have a T4 lesion, or if it is very close to sphincter complex, but you want to do a sphincter preservation, you don't have a margin, or node positive as analyzed by an MRI are indication. So node positivity, T4 lesion, very close to sphincter, but dentate line is free, you can do a sphincter preservation as per the German rectal cancer study are indication for downsizing neoadjuvant chemoradiation. So you give preoperative chemoradiation in these conditions. It reduces morbidity, gives better margin negativity, sphincter preservation is high, anal canal function improves, local recurrence drop from 50 to 5%. So this is where you must do a neoadjuvant. I will summarize it in 3 headings. There are 3 ways you can do neoadjuvant chemoradiation to downsize so that it makes it operable, sphincter can be preserved, negative CRM margin, low recurrence. One is conventional, which is called long-acting course. You give chemoradiation 5040 centigrade for 5 weeks, then wait for 8 weeks, 6 to 8 weeks, then you operate. This is the conventional. This is recommended for mid and low rectum when you want to do sphincter preservation. Another is short course, Swedish. Only 5 doses of radiation. Day 1, 2, 3, 5 fraction, 5 day. Within 1 week you operate. This is called Swedish. This should be used only when sphincter preservation is not an issue. For upper rectal tumor, local recur control. This is not a standard of care. This is not a high level evidence. Long course is the standard of care. But short course can be used if you have a rectal tumor with a liver metastasis. So you have to manage both. You want to, not lose lot of time, then short course. Or upper tumor, where sphincter preservation automatically can happen. Now a new thing that has come, recent advances, is called as TNT, total neoadjuvant therapy. Finish off all the radiation, finish off all the chemo before you operate, then only surgery is left, so no chemo radiation later. Always chemo radiation before surgery is better than after surgery because adhesion sets in, vascularity is gone, complication is high. So TNT means short course radiation for 5 fraction, then complete 4 months of chemo, then operate. So these are the 3 strategies available now. Now a new evidence is suggesting TNT therapy. Radiation chemo finishing in the short course of 4 months and operating probably has a better survival. You can look at this MERCURY Study. Don't ever operate a patient of rectal cancer without MRI. MRI is mandatory. If you do MRI, not CT, not PET scan, not ultrasound alone, you can identify type A tumor confined to rectum, type B1 tumor, mesorectum breached but outer layer is negative, B2 outer layer of mesorectum is gone, C it is invading the surrounding area like bone, prostate. So type B2 and C you have to give neoadjuvant chemoradiation and operate even if they are operable, otherwise local recurrence is very, very high. Second part is autonomic nerve preservation. We have 3 nerves. Superior hypogastric plexus where we tie the inferior mesenteric artery IMA at T12L1 level, and hypogastric nerve below and nerve laryngitis which are mixed. I will show you. Then we have inferior hypogastric plexus at the lateral pelvic wall, then cavernous nerve inside the diamedular fascia. I'll show you this particular area. You can see that. So this is the plexus. Then you have inferior hypogastric nerve, inferior hypogastric plexus where nerve laryngitis join. So if you look back the same way, see this, this is the inferior mesenteric artery, and you look at this particular nerve, this is the plexus. So this is the superior hypogastric plexus, right and left Y-shaped hypogastric nerve which is there, and you can see the same thing at the sacral promontory, inlet of the pelvis. You have superior hypogastric plexus, Y-shaped left and right. They run 5 mm to the medial of the ureter called as space 0 and 1. Laterally, they are joined by nerve laryngitis parasympathetic. They form a mixed nerve. Then they go inside the diamedular fascia and they supply the sexual function. So if you understand this particular area, 4 points where it can be injured. When you tie IMA, when you do posterior resection at the so-called posterior rectosacral ligament, or laterally where these 2 join, or anteriorly at the diamedular fascia. So when you operate these 4 areas, nerve are at high risk to injure, be careful. Now look at this particular area. You can see that this is ANP surgery, autonomic nerve preservation. Sacral promontory, pelvic inlet, the main inferior superior hypogastric plexus. Then you can see right and left Y-shaped hypogastric nerve. They go laterally and they join the nerve laryngitis, cavernous nerve, then they go to sexual function and urinary. See this again, I'm showing you. They're always about 5 mm medial to the ureter between the midline, which we call space 0. So you have to be very careful. So this is how the nerves are there, you must make. If you do both nerve preservation, 90% of the time sexual bladder is functioning. If you cut one side nerve, 80% it works. If you cut both sides, 80% it doesn't function. So this is a very important. So try to preserve both sides all the time, which is very, very important. There is a study trial which I did and published where if you do a minimal access surgery in the robotic, the nerve preservation chance is very good. And the functioning of these particular is better than any other open surgery. Second is now the concept of no touch isolation. High ligation is not recommended. A trial Turnbull high ligation showed that there is no benefit, no need to take IMA at origin unless there is a node. You can preserve the left colic. So this is very, very important. But the advantage of high ligation is easily in a ultra low LAR, the descending colon comes down to leave trachea for anastomosis. Splenic fixture mobilization, mandatory, coupled with IMA taking, can get the rectum down to the anal canal for intrasphincteric. But beware, if a patient is obese, smoker, or atherosclerosis, if you ligate IMA, the marginal artery of rotum may not be fine and you may develop leak and necrosis. So it's very important to understand. Beginner IMA, if you ligate at high level, nerve injury is high, vascularity problem is there. So be careful. See that this is one. But if you can always take all the nodes of IMA, leave the left colic and then take this particular area, which is important. Second is this a very important paper which showed that rectal washout and using circular stapling device actually has a better outcome. This is only one of its trial which was published and which gives a good margin. Now, what is a good distal margin? In well to moderate differentiated rectal cancer, 2 cm distal is enough, mucosal. But the mesorectum has to be 4 cm. But if you give neoadjuvant chemoradiation, 1 cm is acceptable margin, but you have to take a higher margin if it is poorly differentiated tumor. So this is very, very important. Avoid coning when you do this. Lateral lymph node is, you don't do an interiliac obturator node dissection in rectum routinely unless it is a T4 lesion or on an imaging preoperative MRI or CT scan you see a node, then you remove this. But lateral lymph node positivity is not a good prognostic marker. You can go back and do lateral lymph node. This is a Japanese classification, space 1, 2, 3. Space 1 is between the midline and ureter where nerve is there. Space 2 is between ureter and internal iliac artery where TME happens. Space 3 is lateral lymph node dissection between internal iliac artery and obturator. I'll show you this figure. You can see this. Space 0 where nerve is there. Space 1 ureter and TME. Space 2 is between the internal iliac and ureter. Space 3 is where you do lateral lymph node dissection. Space 0, 1, 2 and 3. See this again, you do lateral lymph node dissection like this only when there is a node seen on the imaging or it's a T4 lesion. Intrasphincteric resection is if you have a young male, well differentiated tumor, chemoradiation you have given, you can either use this Nitilon non-staple device where a ring stays and it falls down, or you can put a Lone Star retractor in the perineum, retrieve the specimen from below and do a coloanal Hansian anastomosis to preserve. So you achieve that negative 1 cm margin. So sphincter works well. Young male, external sphincter can be preserved. The role of SLNB is limited. It is not a high level evidence. If you do a sentinel lymph node, 13% of the time, because you do ultrasectioning, you can actually identify this. You can use either ICG probe, or you can use a gamma probe, or you can use a blue dye. Even after removing a specimen, you can give methylene blue peritumoral and you can see and the node and send. If you do multiple section, those what you think as node negative 11% can be upstaged. So these are the advantage of sentinel node. Skip metastasis can be identified, ultrastaging can be done, more node yield can be given to pathologist, and you can really identify truly node positive where chemo radiation would be required. Now role of MIS, minimal access surgery. Initially it was thought that laparoscopy may not be safe, but now there are multiple randomized trials which showed that, enormous trial, these are all the randomized trials which showed laparoscopic or robotic minimal access surgery in rectum is as safe as a open surgery oncologically, and patient has all the benefits of minimal access. But remember, this is only for T3N and not for T4. Non-obstructive, non-T4 lesion, it is equivalent. So the outcome is all same, but the recommendation, what has been given is learning curve of 20 to 30 should be passed, and you should not have port site recurrence more than 1%. You must do at least 12 to 15 cases a year, and you must have a good laparoscopic or robotic skill and expertise which is there available. The next level of laparoscopy is the robotic, because it has got a fixed system, forearm, 3D vision, less camera, tremors cancellation. The result says that TME can be easily performed with robotic. You can transect the rectal stump directly straight, and you can actually omit the mini laparotomy. You can go and then do the retrieval of the specimen directly from the anal canal. So you can actually go and then take the specimen which is possible through the anal canal. And you can also see that you can control the intraoperative bleeding very, very well. You can, with the robot, you can take that very well. And you can see, you can pass a nice umbilical tape in the robot. You can take a fixed platform. You can just go back there, hold it. See this is the VLPF and PLPF. You can see that this is the parietal layer, visceral layer, holy space of healed. Lift with the third arm of the robot. You can go down, and because of the endorist, you can create this space between this. See, this is a rectosacral ligament. Cut it sharp. Go down up to the levator rene, bloodless, no harmonic required, sharp dissection, bilobed like a baby's buttock, and do a lateral dissection sharp but not with harmonic, so the nerves are not burnt. Sharp dissection laterally when you go VLPF, PLPF join and lateralize the nerves. Do a very good nerve preservation technique here. So this endorist really helps you. You can see that all the nerves can be preserved. The parietal layer is preserved there. So you go in the bloodless field, and then you can cut this sharp area, and the camera is 3D. Then anteriorly you can see this is a 2-layer between denovular fascia. This is a type 2 TME. You can see one layer of denovular fascia is with seminal vesicle and then prostate. The second layer lies with the rectum. You can lift this, and beautifully you can do a autonomic nerve preservation, and you can cut it very, very sharp. The third arm stabilizes, the camera doesn't get fogged. Postero-lateral angle of the prostate where the nerves are there are intact, and you can do a very, very beautiful nerve preserving technique. And this was a randomized control trial done and published, which showed that nerve preservation and TME was very, very good. You can also do ICG in colorectal cancers. When you do ICG in colorectal cancers, it shows where the vascular demarcation is there. If you give ICG and throw a green light, either with laparoscopy or robot laser, you can clearly see where the tumor is ending and where actually the cancer is beginning. You can see this, So if you give ICG IV, within 40 seconds, after you complete an LIR, when you mobilize the spleen fracture, you can know where the descending colon is vascular, not vascular. So you know where you place the anastomosis. So this is the ICG going down. Look at the rectum. Now you can very clearly see where there is a demarcation line, and that is where you can keep the anastomosis, so it will chance of leaking is very less. This is a steady randomized trial done and published by the groups, our group, which showed that visual eye only 15% of the time you are accurate. When you use ICG, 76% it adds more value for you, and this is a publication you can go back and read. Now if you have a colorectal cancer with liver metastasis, this is one stage 4 where if you can resect both, people are still cured, but you give chemo, the tumor will shrink, go back and do liver resection and a primary colorectal resection, and when you think it is inoperable, giving chemo, downsizing and operating, 50% of the time you can go back and resect. So remember, rectal cancer with liver mets, both to be operated after chemo, still 50% cure rate. Suppose you open a rectum for cancer surgery or there is a peritoneal disease. Stage 4, selected patients with limited peritoneal disease, if you do hyperthermic intraperitoneal chemo, HIPEC, then 40% of them can be cured. So this is something, remember this is a randomized control trial which showed low peritoneal carcinomatous index. If you do a hyperthermic intraperitoneal chemo with this pump, mitomycin with 42.5 degree heat for 90 minutes, selected patients with low peritoneal metastasis can be cured, and this is a randomized trial which helps in limited peritoneal disease. So in conclusion, multidisciplinary approach to the treatment is very important. Good treatment at right time, multidisciplinary approach, good MRI, good evaluation, good surgical technique, holy space of healed, autonomic nerve preservation, TME, preserve the sphincter, distal oncological acceptable margin and CRN, circumferential negative margin, restoration of coloanal anastomosis in continuity, post-surgery, continence, bladder, sexual function, all can be preserved. See, if you look at the way, if you do a proper TME, it is very, very important to understand that very nice nerve preservation actually can happen. So it is good TME actually leads to a very good nerve function. You can see that now, when you do this particular nerve preservation, see how in minimal access it would look. See this. So a good TME is done. This is the inferior epigastric plexus. This is the left now, right now. Not a speck of fat because you have done a total mesorectal excision. All the nerves preserved. Liver training is seen here. And then the rectal stump is here ready to be restored. A good TME done gives a very, very good locoregional control and then excellent surgical technique which can be done. And then even more beautiful is if you do an intrasphincteric resection, actually you can remove the specimen through perrectal when you are lower down, pass the anvil down, beautiful purse string you can put with robotic or laparoscopic, go down and take this purse string and you can do a sphincter preservation and a good TME. So this is something which I want all of you to understand. Ultimately, it is a zenith of surgical technique. So what is most important is, I'll come back to my last slide of all the thing I explained with take-home message and conclusion. Good treatment at right time, able to do good distal margin, restoration, continence, bladder and sexual function. Remember, key for success is expertise, minimal effective treatment, multimodality, organ preservation, optimal multidisciplinary approach, a tenacity. Rather than a single battle, it is a group team which to be done. Thank you very much, and I'm very happy to take any question with me and my moderator, Professor Lakshman.
Professor Somashekhar, hearty congratulations on what I think was an excellent presentation.
Thank you very much.
On a very difficult topic like carcinoma rectum. It has been a pleasure for us to cover such a vast topic in a comprehensive and a very clear manner. You stress on the importance of circumferential clearance, which has been a concept which has been around for the last 2 decades and has taken a lot of importance in the recent years. You have clarified about the indications for neoadjuvant treatment with bulkier tumors and the node-positive tumors deserve neoadjuvant treatment to downstage the disease and then undertake surgery. Before we go on to the questions from the audience, and they have started coming in, I would like to ask a couple of questions and get your answers on that. You mentioned about
at the outset, I want to thank Professor Lakshman. He is such nice words coming from a very senior person who is so respected by all of us. An excellent GI surgeon, minimal access surgeon himself, a great teacher, academician. It's a big honor to get such nice wording from him.
Thank you very much indeed. My first question to you is, we were talking about, briefly touched upon the local excision of an early tumor, and we talked about the MRI and endorectal ultrasound as a modality of investigation to look at. Before we go on to the questions from, what would you prefer, or would you like to have both as complementary to each other?
Yeah, it's very important to know in a country like ours, when you have an early tumor, you must be very careful. That is where you may under-evaluate, lose a potential chance of actually curing that patient if you wrongly evaluate. The whole concept of local excision is they're not malignant enough potential to cause lymph node metastasis. So what are the factors for lymph node metastasis? T size, so the depth of the invasion, the grade of the lesion. We all know that the pre-surgery colonoscopic grade is not 100% accurate. So sometimes we may go wrong. Third most important thing is, what is the involvement of the tumor? In the old time, endorectal ultrasound by a very good sonologist, because it's a sonologist dependent with a high frequency probe, was good. Since you want to remove the subjectivity, and if you have endorectal coil, MRI is good, but I always do both. Because it's very important to understand, MRI is not a dynamic scan. You get a static image at that moment. Even though you can full water, you can do. Whereas an endorectal ultrasound is a dynamic image. So you can know the distance from the endorectal ring and everything. I would prefer both. If you have an excellent sonology which is user dependent, then endorectal ultrasound is very good. But if you don't have, MRI sort of standardizes. There is one landmark trial I need to tell, which we call that MERCURY trial. If you look back, remember MRI of pelvis and rectum is not same as evaluation of MRI with contrast of the rectum. I would say that there are 9 criteria which are enlisted in a trial called a MERCURY trial. What is the type of the machine, how it should be studied, what sequence it is. If you follow that protocol, that trial which was there on Dutch showed that you are accurate in analyzing local regionally, and then you can do that. So this would be the answer for that.
Very nice. For the postgraduates who are watching this transmission, I would like to stress that every single thing that Professor Somashekhar mentioned was evidence-based. As a big proponent of evidence-based surgery, I again congratulate Professor Somashekhar for his excellent effort.
Thank you.
Let me take a question from the audience at this stage. What is the package difference between a regular surgery and a robotic surgery, sir? Are we to answer this question here in terms of costs, and that's probably what he's asking? Are we to confine ourselves to?
I'll put an evidence-based science, because in science, cost is a corollary.
Yeah.
So science is first, but I would just say that there's only one randomized control trial which took laparoscopy versus robot head-on. That's the ROLAR trial. It's a prospective randomized control trial. In colonic surgery, as of today, the robot has no superiority advantage over laparoscopy. It's very important to understand. Only in transverse colon, technically, if you are not so proficient in laparoscopy, robot helps. But oncological outcome, clinical outcome, not superior. Upper rectal tumor, there is no superiority of robot over laparoscopy. The ROLAR trial showed benefit only in male patients, low rectal tumor, and when they're close to sphincter. In these places, there is a Dutch TME analysis which you do after you remove the specimen. Complete, near total complete, and incomplete. Incomplete, none of them are cured. Near total, the recurrence rates are more than 10%. So it was found that in male patient, low rectal tumors with robot, as per the Dutch TME criteria, complete excision, which means if you have a high gauge, you must balance the cost. A person is a fool if he doesn't take cost into healthcare system. So I would say I would use robot in a male patient in a low rectal tumor. And cost is a relative phenomenon. When laparoscopy came, single chip camera was there, you use monocular, cost was different, then 3-chip camera, 3D camera, vessel sealers come, the cost is different. As more and more companies come, the cost will come down. I don't think we should based on cost, we should see what are the evidence at this moment and where it sits.
Very rightly said, while cost is an important factor, that's not the only factor. There is a person, a young man, who can get away with a colostomy because of the use of any technology, including robotic technology, where you can get away with an ultra low AR, for example. At least the service must be offered to him. Whether to have it, accept it or not at the given cost is left to him, really.
See, for postgraduates, I would summarize what is that robotic and laparoscopy different. Remember, there is nothing called robot laparoscopy. All are MIS. They are a part of MIS. You do through laparoscopy, or you use a computerized system to do the same. So the only advantage of robot has, per the evidence, is the learning curve to do a robotic surgery is little short. In the MRC trial, which was laparoscopic rectum, the open conversion to open was 30%, then it came down to 20%. But now in Korean trial, it is very less. So one other advantage is conversion to open during your learning curve is low. It's very important to understand in COLO-RECTAL, if you start with MIS, you end up doing open surgery, their survival drops down. So whatever technique you start, complete in that. If you think it is not, then complete in open. So short learning curve, less conversion rates, standardization of the technique, but a good laparoscopic surgeon would do the same in robotic. So the advantage would be male patient, low rectal tumor close to sphincter. This place, it takes advantage.
Another question, how would you assess the distal margin at the time of minimal access surgery?
Now there are two important. If you have an upfront patient where neoadjuvant chemoradiation was not required, or a patient who took a neoadjuvant chemoradiation and then assessment is very tough because they are end up with a bland ulcer. Now the right way, because in laparoscopy you would staple the distal stuff and there is no looking back. If your margin is positive, to redo it, it's almost either in APR, very difficult to. But in robot, You can do an open transaction, transanal retraction you can do. But I will tell you for the sake of evidence-based, the right way to analyze distal margin is a good preoperative evaluation before taking it. Good sigmoidoscopy being done. What I normally do is when the patient is anesthetized, relaxed, remember when we say 2 centimeter from anal anorectal ring, they are not flexible scopy guided. Traditionally, it is a rigid sigmoidoscopy done by surgeon on table. So I would, once the patient is anesthetized, put in lithotomy position, I would do a beautiful digital examination, study the MRI again, which has been done before chemo-RT and after chemo-RT, and I would pass the rigid scope and evaluate where it is. So I evaluate and I know. Second thing is there are techniques where you can do a tattooing before and you can do tattooing after. But there is one more limitation of distal margin. The distal margin is 2 centimeter, but mesorectal margin is 4 centimeter, which means always and always once you have a mid-rectal or low-rectal, you're going to transect just above the levator drainage and you get that margin. Rarely in less than 2% you end up with a disaster of positive margin.
Here is a comment complimenting Healthium and the transmission. I'm just reading it out for you. Excellent presentation, very lucid and fluid, crystal clear, very good transmission today. So that's something we should be happy with.
Thank you very much.
We go to the next question. Is there any role of neoadjuvant radiotherapy, either short or long course, in upper rectal and rectosigmoid tumor?
See, it's very important to understand the reason for which we give neoadjuvant radiation and chemo. Number one, because it's a loco-regionally advanced disease in terms of more than T3 or N+, so you want to reduce the loco-regional recurrence. Purpose one. Purpose two, it is close to anorectal ring but not invading, and sphincter preserve option is there. Short course will not serve the sphincter preservation, but it adds loco-region. Now, if it is upper rectum touching the rectosigmoid, you have to evaluate, is it more colonic and less rectum, then I would not give upfront neoadjuvant chemo-RT. The reason is none of the randomized trial has shown an overall survival benefit with neoadjuvant chemo radiation, but better DFS and loco-region. So if it is in an upper rectum at rectosigmoid, not coming down to 12 centimeter, the role of neoadjuvant chemo-RT short or long is not very clear. But if you don't know whether it is coming to rectum but behaving like, that is the only place I use short course. 5 fraction, then 5 days later we operate. Or you have an upper tumor at presentation liver lesion. Then we need to start with chemo, which would be 4 months. Then if you do conventional RT, again you lose another 1.5 months, 6 weeks. Surgery comes after 2 months. So that is the only place where I use short course. So pure rectosigmoid, I would operate like colon. Rectosigmoid going down to upper rectum, I would use short course. Upper rectum with liver lesion where chemo is important but local control, then I don't use conventional, I use short course. So these are the places how I would actually evidence-based place them.
All right. Next question is a little out of the main subject but still relevant. He says, when you're operating on an obstructing rectal carcinoma and you choose to do a stoma, would you prefer an ileostomy or a colostomy? And if it's a colostomy, where would you do the colostomy? Which anatomical part of the colon would you do the colostomy?
Okay. See, I would analyze it very, very practically with the experience. Number one, what are the indication in diverting after a curative rectal resection when you anastomosed and restore the sphincter? Remember, just because tumor is low is not an indication. Preoperative radiation usually is very close to an absolute. See, there is nothing called absolute in medicine. We are only a fool if I say 100% this way, that way. But neoadjuvant radiation is somewhere I would always divert, number one. Or if a patient has come in an obstructed bowel, there are 2 options. If you think that this patient is a upper rectum, is not a candidate for RT, then I would request my medical gastro to put a stent, relieve the obstruction, go ahead and try to do a primary resection and avoid a stoma. Now, if I very well know that it's a local advanced, patient needs a neoadjuvant treatment, then diversion is recommended so we don't lose our time and patient nutrition is maintained. After a curative resection and anastomosis, 2 philosophy, ileostomy or a colostomy. Remember, all randomized trial, none of them has shown superior to each other. Ileostomy, easy to do, very easy to reverse, complication are less. This is for you as a surgeon. But For patient, not very good to maintain. Liquid stool, excoriation, electrolyte imbalance even elderly. So you have to balance between both. Even though for surgeon, ileostomy is easy, complication are less. Most of the time, if you opt a colostomy, patient friendly, surgeon not friendly, then I would see what is the type of anastomosis I have done. Is it a colo-anal anastomosis for an ultra low LR where spleen fracture is completely done? I would do to the right half of the transverse colon so that I don't disturb that splenic fracture which I have taken down. If it is sort of a anti-resection or not a colo-anal solo, then doing at sort of to the left of middle colic to the left is okay. Having said that, my protocol always is to do a loop ileostomy, which I reverse it early.
We were discussing a situation where after completion of surgery, you encounter a situation where the margins seem to be positive. And Professor Somashekhar was telling us what we do in that situation.
So we should, the best thing not to end up like that is to do prevention, which means proper pre-op evaluation. When the patient is induced and put in lithotomy, try to do a rigid scopy and analyze where it is. Study the MRI well. And when you fire it, before that, the best thing is intraoperative limited sigmoidoscopy to look where it is, which all center may not have, but that is the gold standard to do it. In spite of all this, either your mistake or whatever reason you want to blame anybody, you end up with that scenario now, which you should not end up if you do proper evaluation. Is if it is a mid-rectum and you still have enough stem, then what I go and do is I take 4 stay suture and I pull it out and I pay 1 more stay. If it is a low, ultra low LIR and you're on the liver draining, I would actually convert it into an APR, keeping patient's best interest in mind. And always when I do for low rectum, I have a consent with the patient upfront that I may convert to APR and colostomy. And don't ever go thinking we are gods and then no consent, then definitely you have to revise back. A positive margin in GI cancer, anywhere from esophagus to the anal canal, no cure. No radiation is going to compensate. If you are lucky mid-rectum, take 4 stay suture, pass 1 more stapler, re-staple, lucky. 10-20% you can salvage, not always. If it is ultra low LR, there is nothing, I convert it into an APR. Rather than saving my skin today and catching the patient back after 3 months.
As Professor Somashekhar rightly pointed out, consideration of getting an oncological cure is even more important. And just to avoid macroscopic disease, hoping that an adjuvant treatment would handle it, that would be clearly incorrect. We have 2 more questions. The same person asking both questions today. He says, can you give us clear indications for sphincter saving operation? So that's the first of his 2 questions.
Okay. Anywhere you can leave a functioning sphincter which is nervated, you should be able to do if you can achieve 2 centimeter distal margin, circumferential resection margin. But remember, sphincter preservation now is not alone. There are many patient factors. What is the age of the patient? Comorbidity like diabetes, neuropathy, pre-surgery sphincter tone, frequency of the motion. Don't end up with a sphincter left which is not functioning and doing a perineal colostomy. So I would evaluate a patient before he goes to surgery, the sphincter tone, quality of external sphincter, and oncological cure. If it is achieved and patient can maintain well in a good mental status, because remember, when you do ultra low LR, as per all the randomized control trial, first 6 months, patient was 10 to 12 treatments. Practically they run to low and year. After 6 months, it stabilizes. And at the end of 1 year, the quality of life, whether you do a pouch-based system or a direct, is same. So I would like to see in what phase that patient is. If that patient performance stage is ECOG1, semi-bedridden, no caretaker, then I would be careful. So I would preserve sphincter in all the patient where patient factor are conducive, oncological like a negative, achieve negative. I preserve the nerves and intact sphincter, and also pre-surgery evaluation of sphincter is fine. I would do that.
The second question from the same viewer. What would be your approach, I presume, for the primary operation when you're planning it? If the patient has more than 2 metastases, synchronous mets in the liver?
Okay. See, when you have a colorectal cancer with systemic mets, either liver limited alone, lung is one of the few stage 4 cancer in the body. If you can treat both locoregional primary and systemic disease in combination of multimodality chemo, they can be cured, and they have same cure rate as stage 3, which is 50% at 5 years, 30% at 10 years. Now, there are 3 categories you follow: A, B, and C. A is what scenario you are telling. No tumor more than 5 centimeter. Number of metastases less than 5. Not bilobar disease. Confined only to liver. And locoregional treatment disease is operable. They are called as type A tumor. They are the only patient where I operate upfront. When you do metastatic disease, the approach is always metastatic disease first. Locoregional is rarely inoperable. When you give chemo, it is always operable. And if you don't achieve R0 at metastasis, no amount of local treatment is beneficial. You will add morbidity. So my approach would be type A, I do both. Type B, go to neoadjuvant chemo and first metastatic site, liver or lung. And if I achieve R0, then I face the rectum. Otherwise, I don't do. Type C cannot be cured. We are not gods. They are ending up with medical oncology for a palliative treatment who may still live for 3 years.
A compliment for one of our viewers, and I second this wholeheartedly. She says, outstanding talk, very informative. I've never understood rectal malignancies and treatment modalities better than how Dr. Somashekhar has described it today.
Thank you very much.
Yes, indeed. Yes, as I said, I definitely wholeheartedly second that. Another comment, very nice presentation, sir. It says, how to assess distal margin? I think we have just answered that. Yeah, and at what level can the sacrum be resected for locally advanced rectal malignancies?
When you do a sacral resection, which is required in very selected patients, posterior T4 and not responded very well, you must always leave S1. If you leave S1 segment and resect, 75% of the time patient is continent. If you leave S2 segment based on the location, very close to 100% are continent. If you remove S1, none of them are continent. So I'll always try to see minimum S1 I leave based on the location. If I'm lucky and the tumor location is such that I evaluate the patient well, S2 I can do that. We put a thumb pins and then we take it with a cautery and a saw and cut. So S1 compulsory, otherwise patient ends up with such a bad quality, no use giving a cure with keeping your vegetables for nothing. S2, if you can be lucky, you can do that. So this is the recommendation when you do sacral resection.
There is a rider on the intraoperative positive margin. The very, very valid question. It says post LPLND following NACT, neoadjuvant chemotherapy. What will be the intraoperative decision if the margins are positive at the end of surgery?
There is a 2 randomized trial. If you look at MSKCC trial, which looked at giving neoadjuvant radiation with the purpose of sphincter preservation. In the trial, when you have a low mid or mid rectum or low rectum, very close to sphincter renal complex, but sphincter renal complex is not involved, by giving neoadjuvant chemo radiation, 72% sphincter preservation was possible. And they also brought another corollary. In a well to moderate differentiated tumor, neoadjuvant chemo radiation, 1 centimeter margin is adequate. So in spite of that, if it is a low rectum margin is positive, I would definitely convert it to video. I know that those patients are not going to be cured. Sure. And remember, downets are not margins. Downnet is one part of the margin. Margin should be in total 1 cylinder base, and I would not achieve it. So if I have a low rectum, if it is margin positive by any means, microscopic, R1, R2, I'm going to convert it into any area.
This is something which I don't understand completely, but it says, is the proximal colon to be taken, let me see it again. Do you have to take the curvature before doing anastomosis?
Okay, I believe that probably the extent of proximal colon mobilization and splenic flexion.
Oh, maybe it's splenic flexion.
Splenic flexure mobilization is 3 types. Type 1 splenic flexure, type 2, type 3. Go back and read what is type 1, type 2, type 3, the band, the vein, the vessel, and then opening the omental bursa, doing omentectomy and then taking. They analyze three important factors. Complete spleen flexure mobilization, opening the lesser sac, how much length it gives to come to levator, point number one. Taking IMA at origin without spleen flexure, what length? Taking IMA at origin with spleen flexure. Taking IMA after left colic with or without spleen flexure. You'll be surprised to see taking IMA at origin added 60% of mobilization even without spleen flexure mobilization. Now, if you preserve the left colic and take IMA after that, most of the time spleen flexure mobilization is required. It is very, very important to understand. Don't shy away not doing spleen flexure mobilization. So, if you do complete spleen flexure but you don't take IMA at origin, only 30% mobility has come. The maximum mobility is IMA at origin. Second is spleen flexure mobilization and taking IMA after left. And taking inframesenteric vein below the lower border of the pancreas adds 10%. So now you can look at, you have a obese patient, diabetic, high BMI, don't take IMA at origin. The chance of necrosis is very high. Do a good spleen flexure mobilization. Take IMA at origin, has no impact. Take IMA after left colic. This would be the message I would like to give to a student to start with.
And could I add to that, Professor Somashekhar, that if you're doing minimal access surgery, mobilization of splenic flexure is sometimes seems to be many times, why sometimes, a lot more comfortable than an open surgery.
And especially if you can give a head up at that moment and then the momentum falls down rather than working above. However, one more option is if you have a laparoscopic ICG camera or a robotic ICG, you can give ICG and see where is the level of vascularity and then choose to decide to further mobilize spleen flexure or not.
There are a few more messages of giving compliments about the talk as well as the discussion that we are having. On behalf of Professor Somashekhar and myself, I would like to thank all of you for your very active participation. Please keep it going. It makes very interesting, makes the webinar very interesting and very useful. Thank you very much once again. The next question, what is the protocol for managing solitary liver metastasis with operable rectosigmoid neoplasm?
I already answered it, but in order not to have repetition, I will clarify it very clearly. Type A, Type B, Type C. Type A means resectable metastatic site, less than 5 centimeters single measure, less than 5 numbers, not bilobar, liver alone, operable rectal cancer, you do upfront surgery without neoadjuvant. Type B, both are resectable, but you have a T3N plus and you have more than 5 centimeter, bilobar more than 5. You give, even though you can resect, you should not. There is a very nice trial from the Rennie Adam group from Paul Morris Hospital that if you give 3 months of neoadjuvant chemo, then you operate. Now the second question, upper rectum, I would not do conventional long course because already 3 months of chemo you've gone, radiation if you had 6 weeks, then you have to wait 7 weeks, it is not conducive. That is the only place level 1 evidence, short course RT to rectum. So I would give 4 cycle chemo, short course RT 5 fraction, within 5 days I operate. So I have taken control of everything because sphincter is not a fault for us. So this is my protocol. And if you want to do, first always do metastatic site. You achieved R0, then come back to local, not the other way around.
A question on recent guidelines for ultra-low rectal carcinoma, I suppose ultra-low rectal anastomosis as far as the anal verge is concerned. In other words, I think is asking for the definition of ultra-low AR along with the kind of tumor that you would choose to do that operation.
This bases a lot on the high volume center, your expertise. Don't, just because I showed intersphincteric recurrence and minimal access lap and robot, don't jump into all the low rectum. By dictum, low rectum, most of them may end up with APR initially. But you can salvage selective, well to moderately differentiated tumor. An young patient, no additional comorbidity, nerves and distal margin can be achieved negative, pre-op sphincter tone is good, then I would consider only those patients for intersphincteric colloidal anastomosis. Otherwise, most of those patients, even though you preserve a sphincter, the quality of life is so poor, they're better off with a well done end stoma, and a better quality. So there are two things you must remember. Minimal access surgery, a bad laparoscopic continuation is worst. It is better to do a timely conversion. Timely conversion is better than a laparoscopic continuation. A well done end stoma with cure is sometimes better than a bad performed ultra-low LAR in a patient who is not fit, leading into a perineal colostomy. Always keep that in mind because it's very important. And have a one-to-one discussion with the patient. Sometimes the patient's goal and endpoint are totally different. For them, mobilization, early return to work, better quality of life, and less is there. You'll be surprised there was a survey done about quality of life after rectal cancer. What would you think as a surgeon? You think stomach comes first. For none of the patients, stomach came first. Sexual function, prevention of retractor ejaculation came first. Able to pee normally and hold his bladder in public came second. Last came colostomy. So that's why, perspective is so different when you are in this table. So this is a very landmark quality of life paper. So discuss with that patient what he wants and then tailor make for him. Don't go with preconceived notion of yours and you close that on patient.
I suppose one of the things this viewer is trying to ask is, in relation to the dentate line, where would your anastomosis be in a colo-RECTAL anastomosis?
See, there are two steps. One is mucosectomy, but keeping the sphincter and anastomosing at the dentate line. The requirement of entire full thickness. So I would even anastomose 5 mm above the dentate line if these factors are there. And any males actually do very well in that. No comorbidity. So I don't shy away, keep it 5 mm just above the dentate line. As long as the nerve is preserved, patient is young, no comorbidity, and then margin is negative and sphincter tone preoperatively was.
Choice of stapling or hand-sewn anastomosis is taken on the table, or you plan it even before you start the operation?
It is very important to understand there is no randomized control evidence which shows staple is superior to hand-sewn. A well-done hand-sewn is as good as staple. Stapler is very good during your learning curve, training program, and to standardize worldwide. But after having achieved zenith, both are same. Having said that, there is single staple, double staple, triple staple. Do a hand-sewn. But when it is a low rectal cancer, always putting a lone star retractor, sitting in the perineum and doing a hand-sewn colo-RECTAL is far superior than a stapler, because for staple gun to go in, there has to be enough distal stump to go in for it to fire, which you may not have. It is very dangerous to try to fire, then it will staple and take away chunk of sphincter and it's incontinent. So it's very important to analyze. You have enough loom available for staple to go. If you're not, don't destroy the sphincter, take it down. Second, you are lucky if you can use 31. Rarely you can use 31. I don't know, Lakshman, are you?
It's difficult to do.
Almost it is very tough to use. So which means you end up with a lesser one. And when you use circular stapler, you lose another 5 mm. If it is a patient who has taken out, you end up with stenosis. It's one of those things, sphincter working, patient cure, margin negative, staple, but you can't reverse the stoma. So I would balance both. If I have any doubt, I would always do a hand-sewn anastomosis.
Is involvement of presacral fascia following neoadjuvant therapy a contraindication for curative resection?
No, absolutely not. You must understand what is presacral fascia. It is a PLPF, parietal layer of pelvic fascia. If you carefully observe, I showed a video which was a T4 where parietal layer was voluntarily removed under supervision in a controlled way, so nerve are exposed. It is not a contraindication. It is still curative, but when you remove that fascia, be careful not to open the presacral plexus and injure the nerves.
What is your opinion about TME?
You know that, since last 2 years, it came in a very big way. I have also seen a lot of live surgeries and a lot of demonstration. It came in a very big way that why don't you do? See, the concept came from a concept of cylindrical excision, transperineal excision, not, APR, APE. So they told, why to do like that? Why can't you just go from below and put that? Number one, it needs a gadget, which are very expensive, very limited mobility. Even the most experienced laparoscopic surgeon had high margin possibility. Now there is a randomized trial which got published 6 months before, which showed margin possibility rate are very high,
recurrence rate are very high. So as of today, it is not evidence, high level evidence. We are not yet reached there. It should be done under trial basis in a very high volume center with a very high expert having explained the patient in a trial setting as of today.
For the benefit of the postgraduates, can you briefly say what they do in a TME with the perineal?
See, if you have a low tumors, there are two ways you can achieve in TME. Upper part of achieving TME is very easy by either open, laparoscopic or robotic. The whole problem is below rectosacral ligament S3, S4, and the liver training you come down. So the new concept that came is you sit in the perineum, you put the lone star retractors, you first decide the lower end of the tumor and give that margin 1 centimeter, 2 centimeter, instill hyaluronic acid with silocaine saline, elevate it, make a cut, put a stamp, close that. Now you have already taken the distal margin. Now you have a TME device, which is a cone device, which has 5 mm ligation, which goes under camera. Then you put it down. Now it is like a natural orifice surgery. You're already there. Then do a posterior dissection until rectosacral, cut it, then open the peritoneal cavity. You can choose to put a camera and gas from above. Now do the laparoscopic through that. It is very nice what I told, but all the trials show that still learning curve is very long, limited maneuverability outweighs the technique advantage. CRM margin positivity was high in those groups. So this is what entitles that. So you do perineal dissection, distal margin taken, special device which is used and through expensive, comes to about roughly 3,000 to 4,000 US dollars, and very limited maneuverability because only 5 mm instruments can go in that with limited range of movement. Once you finish the lower part, go to the peritoneal reflection, then you can do the remaining from above, which is just transaction of the left colleague. Beyond that, IMA.
A few more complimentary messages. With your permission, I will skip those messages. We truly appreciate,
this is not the purpose.
Truly appreciate your interest and
your
affection, and of course the appreciation of a highly scientific material, that highly evidence-based material that Professor Somashekhar is giving all of us. I do share your sentiments, and again, once for all, compliment him for his excellent presentation. But we'll stick to some of the more, what I call, meaty questions.
At this juncture, I would want to say, Dr. Raghuram, our present president of ASI, Arvind Kumar, previous president of ASI, Dr. Shivram, who is the head of this. It is their brainchild, and all the thanks and compliments should go to them and not to us. We are just one part of the means of it. And this is what they foresaw, and it is the best compliment to these three great people who foresaw this particular and then brought it to you.
And one more thing that I should mention, for the ears of all the powers that be ASI, particularly Dr. Shivram's ears, I should say, they want you to give similar presentations on cancers in other regions. Being a surgical oncologist, I'm sure in months to come, Professor Somashekhar will happily oblige us. There's something which is very nice, and I was actually going to ask this myself. What can be made to increase the awareness of rectal cancer? We'll all be talking about surgeon-centric, doctor-centric. In terms of preventive issues or awareness among the lay public, what do you think should be done?
We know that prevention screening is most important, and especially most of the people have HNPCC. And then when you treat somebody, an young guy, we forget that all of the family members could be there. That is where a lot of awareness programs are taken through the ASI, through the colorectal societies, the Indian Oncologic Group, and also we have done it with a lot of other companies. Number one, this is at personal level. I educate myself, my family, and I apply it to my family. As an educative body, or if you're in Rotary Alliance or any other group, we apply it like we do an Ironman, or we do a marathon. Do it for a cause. Interact private, public, and doctors, and then have good educative leaflets to all the people across, and run educated talk screening program. I will tell you what should be done at your level. When you have a birthday in your family, you just take your wife, give one diamond necklace, take them out for a dinner, or you take your mother and then take for a foreign trip. On that day of birthday, you ask one conscious question when you get up: have I done a screening of colorectal cancer for my family? That is the best gift coupon. Have you done stood for cut blood? Is a screen colonoscopy warranted because we have a family history of colorectal cancer? It could be HNPCC or FAP. So take your loved dear ones first for a cancer, give them, then you take evening wherever you go. So we in India never do screening ourselves. If you toss, how many of you who are watching surgeon have actually done your own screening? How many of you morning look at the poo you pass and see, do you have melena? Is there any change in the bowel habit? Do you do a guanic test? Do I have a family history? Should I do a colonoscopy myself? Never. So if we change first, then all of us can do a awareness across, joining hands with a lot of public-private people, and then change the whole thing and form a patient advocacy groups, involve them and take help of them.
The question if this program is recorded, the answer is yes. It is recorded and it will be available perhaps for posterity, definitely for a very long time, both on the ASI website where you get the link and also on the YouTube where the Healthium organization will put this recording up. This again, I suppose we need to clarify it a little bit better because another question on up to what distance from the anal verge can sphincter preservation surgery be performed? I suppose he is expecting 4 centimeters from the verge, 3 centimeters.
Okay, I will put it this way. Don't go. See, there are 2 points. From the anal verge is not the right one. Is it patient relaxed, not relaxed, lithotomy, lying down, flexible scopy, rigid scopy, finger examination? We all know that 3 centimeter is what required for a viable. So if I can achieve a 5 millimeter above the dentate line, keeping the sphincter complex with the nerves, I would go ahead and do in a well to moderately differentiated rectal cancer only, preferably with neoadjuvant chemoradiation. Poorly differentiated, I would not do. So don't go by that. In laparoscopic and robotic, you've done as much as 3 centimeter. But remember, it is not the dentate line per se should be free. MRI should show sphincter complex is not invaded. Well to moderate differentiated neoadjuvant chemo is given and nerve preservation is possible. And the sphincter tone before you take for surgery itself is good because of patient factor. I would do it.
I would again stress that it's not just the distance and distance alone that matters. You have to take many other considerations, many other factors into consideration. Would what you say translate to 2 centimeters above the dentate line? That
would absolutely be fine. I would definitely do that.
How would you manage a patient with low anterior resection syndrome?
It's a very big topic now. What constitutes a low anterior syndrome? Treatment factor, patient factor, surgical doctor induced. A patient who has taken radiation before has got more chance of rectal syndrome. Lower the tumor, like if you say 15, 12, 7, 3, as you come down, it is inversely proportional. As you come down, rectal syndrome increases. Number 2. Number 3, the size of the staple gun you passed, or some people have an habit of doing a stretching of the sphincter before you go. That is again damaging. Comorbidity in the form of diabetes, preoperative sphincter tube, any perineal surgery for fissures or fistula or hemorrhoidectomy, all this cause. So in general, low rectal with ultra low resection, coloanal anastomosis, preoperative radiation, high BMI, diabetic patient, and during surgery, if the nerves are not optimal, they have high rectal syndrome. The best thing for them is what I normally do is, once I know a patient operating a patient after radiation, I always invite my medical gastroenterologist to do a holistic approach to see what is his colon transit time, time due, what is the food habit, and what is there. Having said that, all this problem is 6 months. After 6 months, suddenly the quality of life improves. The frequency comes down to 3 or 4. By 1 year, it is same. If you foresee that this patient can have very high chance, that is the only place where pouch can be done. But it is very important to understand simple J pouch in randomized controlled trial are not superior to a conventional end-to-side rectal. So if you do, it should be more than a J pouch. So it's very important to understand. But having a good counseling to the patient before, good diet modification, using medications, not having rashes, analyzing and explaining the patient is very important. But these are the factors. If you can avoid, modify them, please modify.
You mentioned about the improvement that is seen with time. Approximately, what percentage of patients will not improve at all even after 6 to 12 months? Do they end up with a stoma at all after that?
If you see that rescue stoma rate after 6 months is as high as about 18 to 22%. So it's very important to remember that. And don't shy away from doing it if the patient's quality of life is better off putting a M stoma.
Is a diversion procedure mandatory following a well-done hand-sewn anastomosis for LAR?
The only place where I would divert is if the patient has taken radiation. If the patient has taken radiation and it's a coloanal ultra-low, these are the two places. I would not say absolute, but very close to absolute. Otherwise, it is not mandatory. But remember, also keep in mind what is the nutritional status of the patient, from how far they come, what is their financial status. If it leaks, the septicemia and second surgery rescue, can patient withstand that septicemia in small bout? So keep all this in mind, but it is not absolute. Ultra low LAR, coloanal, or if you are given radiation, these two I would definitely divert.
Is there any role, you have touched on it, but I would, because it's asked, I'm saying it again, role for creating colonic pouch to minimize anterior resection syndrome?
I told you that J pouch, if you are thinking, is not beneficial. Randomized control trial showed that if you do end-to-side anastomosis, remember when you anastomose the descending colon to the lower rectum or above the dentate line, the lowermost distal part may actually not be the easiest part to come. You'll be surprised to find 2 to 3 centimeters above is where it comes easily. And distalmost tip may be avascular and leak chances are actually very high in that particular area. So if you do a pouch, it cannot be a J pouch. You have to at least do a W pouch. Otherwise, it has no benefit. So I rarely do a pouch because I do an end-to-side anastomosis. I would do a pouch only if it is IVO rectal anastomosis.
I love this question because of its simplicity and its importance. I congratulate the viewer. I've not been giving the names of the questioners. I congratulate I presume she's a postgraduate or a young lady. Role of bowel preparation in rectal surgery. Okay. You really should have mentioned it up so.
This is very important.
Yeah.
It is like a seesaw. Initially, bowel preparation mandatory, then bowel preparation crime. Like, oh, you do bowel preparation, you are not evidence-based. Yeah. Until last year, March, as per the American College of Colorectal guideline, ERA's guideline, based on the available randomized control trial, bowel resection, neither mechanical nor antimicrobial, didn't make any difference in the outcome. But it changed after 2 randomized control trials got published in American College of Colorectal Journal, also Annals of Oncology last year. There is a randomized trial, very well done, 230 patients in each arm, 3 arms, no bowel preparation, only mechanical preparation, combination of mechanical antimicrobial. Only mechanical preparation was same as no preparation. Antimicrobial with mechanical preparation for left colonic disease, not right, had a better outcome. So since March, as per today, for left colonic and rectum, you can do bowel preparation, but it should be combination of both. And remember, what is the antibiotic they used orally? Neomycin, which is not available in India as of today. So loosely, when we had a thorough discussion, Misopol with mechanical is possible. So for left colon, as of today, evidence-based, as per American College of Colorectal guideline, you do a bowel preparation, which ERA Society has not yet updated, but for left colon you can do. But it's very important to understand, if you do that, don't do it just a day before. So go, especially if you're doing minimal access, you have a bloated balloon, small puncture, and leaky water is more dangerous than a nice fecal matter where you can close back. So you should sort of do it 48 hours before. So having said that, for left rectum, it is okay to do it as per the evidence, but it should be a combination of both.
I might add that particularly in the elderly,
yes,
bowel preparation can give rise to fluid and electrolyte imbalance. And that is something one should bear in mind when you're preparing the patient.
Second line I would like to put, since you asked it. If the patient has presented with subacute obstruction and then you put a stent or you operate in a subacute obstruction colon, you anastomose, don't do ileostomy for diversion if it is required. That's the only place I do colostomy. You do ileostomy, you still have the colon. Ileostomy is bringing what you eat, and the remaining colon is leaking, and that's enough to elicit a small septicemia, SIRS syndrome, and patient will die. So, in an obstructed patient who has been relieved with stent or not stent or semi or subacute, that is one place you do colostomy and not ileostomy, and intraoperative was to remove so it doesn't keep leaking if it leaks.
On what basis do you prefer a straight head stapler or a curved head stapler?
It would depends upon the length. You know, when it is a low rectum, it doesn't matter which one comes. But if it is at the upper rectum or mid rectum in a male patient, curved head would be. But having said that, both can easily be used either way if you do it. But for low one, it doesn't matter. But a higher one in a male pelvis, narrow pelvis against the sacral curvature, I would use that.
And a related question, you might have already answered this, choice between a circular, a tilt top or a usual state.
The evidence says it doesn't matter. It doesn't matter. So if you are a very impatient surgeon, tilt head is something good. Margin of error is less, but after you learn that, everything is same.
Can you tell us briefly about intersphincteric resection and extra-levator area?
Remember, this should be done only by advanced center with high volume patients with excellent skill who has passed through the learning curve in a selected patient after thorough discussion. Now, we all know that we have two types of sphincter: external, internal, voluntary, involuntary. Puborectal is sling, anorectal sphincter is the one which is the hallmark. That is the main. Then you have external sphincter, which is 3. Suppose you have an young male, the inner sphincter is a part of removed, but external sphincter is continent. In an young male, strong enough to suffice, then you do an intersphincteric resection, where you finish all the surgery from above, be open, laparoscopic, robotic, go down until you see the levator vein. Endopelvic fascia, you give a cut, you give another 1 centimeter. Then come back to perineum, put a Lone Star retractor, look where is the tumor, take 10 millimeter or 20 millimeter depending on pre-chemo or not, and then resect it, but make sure you don't damage the external sphincter, and then you bring the colon, descending colon, and do a handstand anastomosis. So this relies entirely on the 3 components of the external sphincter. May not always work, but surprisingly it works very well in an young male to do, and we always do a diverting ileostomy. So this is not a very high level evidence. In a controlled right patient, with patient understanding, one-to-one discussion gives a fantastic result.
Another very important basic question, and an answer coming from you will be very valuable to all of us, all the viewers as well as all the, I meant all the postgraduates as well as the seniors. How do you counsel a patient for an end permanent colostomy?
Okay. We go through this every day. Before I tell a patient, I will do a proper workup, an MRI scan, digital examination, patient background, their comorbidity, what they look at, and the disease status, grade, and male, female, technical difficulty, T4, T3. Then I first convince myself that in this patient, sphincter preservation technically is possible. Remember, there are 2 parts, the science and the art. You might be having the art to preserve the sphincter, science may not permit. In oncology, there is a lot of difference between 2 things. What can be done and what should be done. Both are totally different. That's where ethics, self-regulation comes. So suppose in this patient, I analyze keeping patient factor, tumor factor, and I get convinced this patient can have sphincter preservation without compromising oncological outcome, and I anticipate a good quality of life. Then I sit with the patient. I always explain them. In cancer, number 1, achieving R0 resection, proximal distal CRM, number 1. After achieving that, can I do preservation of sphincter? This comes second. Third, the root, open laparoscopic robot, is last. And I tell them, never in any other order. 2 can never come above. Now, after doing the first part of surgery, I think that I have removed the tumor well, all margins are clear. Then and then only I will restore the continuity. Otherwise, I am going to do an APR. I tell that patient, if you leave long with stoma is better than having a continued sphincter, leaving short or compromising your outcome. And this is how exactly I counsel. Cure from cancer, complete removal. Restoring the sphincter, avoiding permanent stoma, and then minimal access. Never other way around. And I tell the patient that even the best of best evaluation, I say I preserve, there's a 20-30% chance I may to end. And then you should wake up and thank me for being your friend to take the right decision for you, keeping your life as first priority and not my ego as my first priority. This is exactly how I counsel. You'll be surprised. Patient will be very frank. They're very happy. And they say, sir, take goal 1, goal 2, goal 3 only.
I would second that. When we talk about complications of surgery, when we talk about negative outcomes, people think that patients will go away or get scared and not have the surgery because we are being very factual. I'm sure it is an experience, my own experience and the experience of many people across the world, that patients actually appreciate your honesty. What matters when you give them the possible negative impact is your body language, choice of words, and the encouraging way and tone with which you describe these things and encourage them to have the surgery. Because there's one simple truth: the bad that the surgery, potential bad that the surgery can do, is far, far, far lower than the bad that the disease does. And so you need to have that surgery, and if you explain it in the right way, it's never a problem. But
patients love most honest, frank doctor. The most successful surgeon is one who is frank and honest, treating the patient like their own relative, than a most skillful patient who is not honest.
The previous question, going back to that, Somashekhar, perhaps he's asking, what are the things that you're going to tell the patient in whom you have decided that he's going to have a permanent colostomy?
Okay. Now what I do is, if I foresee a patient has a stoma, be it temporary on this, we are lucky in Bangalore, we have Ostomates Society and Association. Every patient, they have brought a beautiful book, which is translated in almost all regional language. First, I'm going to give that booklet to the patient, which covers everything. Can I have normal life? Can I have normal relation with wife? Can I be with pets? Do I smell? Can I do insert? Can I travel? Can I drive? Is my life normal? Can I share meal with other people? All are answered in regional, number 1. Number 2, I always, before I operate, fix up a consultation with an ostomate stoma nurse. It may be a patient or a senior nurse going to their home in their environment to counsel what it is. And I always give a database of the patient who have stoma, and I tell them to go and meet patient advocacy group and do. I always do these things. So that in this order, Ostomates book available on website, please download all regional, give that book. I tell the patient, read, we meet back this weekend. Surprisingly, questions are half. Then I fix up an appointment with stoma nurse. Number 3, I would make them meet another patient who has it. After that, they come back and I answer 1, 2, 3. No violation. All the time I do these 3. And it's very simple to do it.
Well, I would second that completely. Particularly, of course, you need to do it with the permission of the patient who has had a stoma. One potential patient, meeting a patient who has had a stoma, makes a huge difference to the emotional status of the patient who's going to have a stoma. Friends, all I can say is that I have enjoyed this thoroughly. My heartfelt thanks and congratulations go to Professor Somashekhar. It has been an exhilarating afternoon of 2 hours for me. Like all good things, this also has to come to an end. We can't go on forever. I'm sure you all have things to do like we have. And I'll just have to make a few remarks before we close the session.
I would just add one thing. Remember, the main thing about teacher is not spoon feeding. This is not nursery LKG. A purpose of a teacher at this level is to show direction. And rest, you must walk through the path. If I hold you and make you walk the path, you will never learn. We stimulate you with ideas. I show you the path and topics, and you have to walk through that path and come back only for doubt. So we should give, we should leave little so you are not so excited. You go back and read and stimulate it. So I would thank Professor Lakshman, my senior guides. He's a guy who is a fantastic GI surgeon himself, which a lot of people learn. Humbly, he has come on Moderator and ASI and also the Healthium for him do a fantastic function.
Yeah, there's a few things I need to say before we sign off. Total number of people, number of lines which logged in was 663 for this program.
Record.
Congratulations yet again. And the number of people watching this has been 2,700. a mind-boggling number. We are truly humbled and thankful to all of you for logging in. I would again thank ASI, all the leaders at the ASI, Healthium, who made this possible. I think a program like this is the need of the hour, and I must thank these visionaries in ASI and the sponsors like Healthium who have come forward and have made this possible on behalf of all of us, including the viewers and all the participants. I would like to thank ASI and Healthium again. And before I sign off, I need to remind you that the next webinar is on the 18th of March. It is given by Professor Sandeep Kumar, the editor-in-chief of Indian Journal of Surgery, and he'll be talking to us about varicose veins and chronic venous insufficiency. We sign off at the moment, thanking all of you once again for participating in such large numbers. Thank you, viewers.
Thank you very much.